The next presentation is an interesting case from Dr. Watanakitch Mutirangura. Right now, he is working at the Nakhon Ping, Chiang Mai province in the north of Thailand. He's going to talk about the interesting case for the short neck AAA. Dr. Watanakitch, please. Yeah.
Thank you very much. Good afternoon, everyone. First, let me introduce myself again. My name is Watanakitch Mutirangura from the Nakhon Ping Hospital, Chiang Mai, Thailand. Today, I have an honor to present the interesting case in short neck abdominal aortic aneurysm. So let's start with the case. The patient is male, 74 years old. Underlying disease is hypertension, dyslipidemia, and diabetes with a history of chronic smoking. I was consulted by the emergency department about the patient with a severe abdominal pain. Bedside ultrasound by emergency doctor showed infrarenal AAA size 7 cm. So I decided to work up with the CTA. Let me show you the overall of this CT scan first. Okay, from the CTA, the CTA shows the infrarenal AAA size 7.8 cm with the right CAA aneurysm size around 2.7 cm. But it is a little problem in this patient. As you see in the yellow marker, you will see the PAU at the infrarenal neck. The PAU is located 9 mm below the left renal artery. So the infrarenal neck length is around 8 mm. The neck diameter is 23, 26, and 28. The infrarenal angle is around 70 degrees, and the suprarenal angle is around 60 degrees. From our measurement, we think we cannot do the standard EVA. Furthermore, patient was an elderly and not fit enough to do the open surgical repair. So we decided to do the chimney EVA. The next step, we evaluate the length from the SMA to the renal artery. The length from the SMA to the right renal artery is around 15 meters, and the diameter, as you see from the slide. The length from the SMA to the left renal artery is 22 millimeters. The renal artery diameter is 5 at the right and 4.5 at the left. The length from the SMA to the infrarenal neck is around 35 millimeters. The length from the SMA to the aortic bifurcates is around 165 millimeters. The aneurysm sac is 78 millimeters. The right common iliac aneurysm the diameter is 27 millimeters. The left CIA diameter is 11 millimeters. So the point of concern of this case, the patient have a short neck, angulated, and a conical neck. From the measurement, as I said before, we're planning to do the chimney EVA both renal artery using the endurance tool. And for distal landing, we decide to land at the right external iliac artery with embolize the right hypogastric artery. And on the left side, I plan to land at the common iliac artery. For the access, we decide to perform the cut down at the left axillary artery and make a conduit using Dacron 9 mm and puncture both groin. This slide I will show you the intraoperative finding. After we perform the conduit at the left axillary artery, we puncture both groin, and then we coil embolize the right hypogastric artery from the ipsilateral side. Next, I perform the angiogram to locate both renal artery. As you see from the angiogram, the right renal artery is the downward branch, and the left renal artery is upward branch. So we choose to cannulate the easy one first. As we planned it, the right renal artery is easy to cannulate it. After we succeed in cannulation, then switch the Y to supercore and put the 6 French sheet in the right renal artery. This is confirmed by angiogram. After that, we proceed to cannulate the left renal artery. At first, we succeed to cannulate the left renal artery, but we can put the catheter in the left renal artery. We try many attempts and change a lot of catheter, but it failed due to the direction of the branch. So the last thing we try is to use the aortic balloon from the limb, then place it below the Y and minimally inflate it. Luckily, we succeed to put the catheter in the left renal artery and can change to supracord to put the sequence sheath in the left renal artery. This is the final after we put the both sheath to the both renal artery. This is the stent we use. We use the endurance 2 for EVA and a B graft 5 mm for both renal artery. After we deploy the main body, there is some problem. We found that the contact rim is folded. We try to cannulate the limb from the left leg, but Y and catheter can pass through the folding part. Luckily, we have the conduit at the left axillary artery, so we cannulate the contact rim from above and successful pass the folding area and then through and through Y to the left groin. We use the balloon to pedalate the folding part so we can success to deploy the Medtronic limb. After we deploy everything, we use the aortic balloon to molding the stent. But as you see from the red circle, stent is not fully open from the contralateral limb at the folding part. So we do the kissing balloon aiming to dilate the folding area, but the folding is still present. So we decide to put another bad stent at this area. This is the final angiogram. So there is no endo leak, the branch is patent, and the contrast is good runoff. After we do the chimney EVA, abdominal pain was gone. The patient was discharged after post-operative day 3. This is the follow-up CTA after operation for 1 month. And there is no endo leak, the branch is still patent, and the folding part is not seen from the CT. So the comparing with the prior CTA, the sac is thrombosed and have a minimally regression. So lesson learned in this case, the chimney EVA is one of the options for the unsuitable anatomy for standard EVA that need an emergency or urgency operation. Lastly, may I using this time to say thank you to Dr. Rungruji and Dr. Grisada, who are not only my colleague, but only my mentor. Without them, I won't be able to be here. And thank you, Medtronic team, especially JM and PB for inviting me to sharing my experience. Thank you for your attention.
Thank you very much, Dr. Watanakitch. It's a very good case to solve the urgency problem. Is there any question or any comment?
Can I ask, let Dr. Witawat share some idea? I don't know. Because we have seen 2 common issues about the chimneys. One is the access, that there are many choices for the access, right? And Dr. Watanakitch just mentioned that one of the choices is do the cut down, axillary.
Where is axillary area or infraclavicular? Axillary area.
Just axilla, that's one choice. Doctor, and the second question is with the left renal artery that going up like this, like dancing in Thai, very difficult to put the Y in. Y can be in, but very difficult to put the catheter in. Yeah. So there are also problems that we see. So use a balloon to help pushing it up. That is one choice. There may be another option. So maybe ask Dr. Witawat and maybe Dr. Wang, share your ideas about these 2 problems, access and how to get the catheter inside that upward going renal arteries.
The first question, the conduit from the past. When we start, we cut down like you and made a conduit for use the PTFE. But the problem that I found when we side puncture the PTFE is had bleeding, continue bleeding, and after that we come to cut down and serial puncture on the vessel. Different the puncture may be away together, maybe 1.5 centimeter serial puncture. And finally, I found another way we can do the percutaneous approach from the brachial artery only for 2 chimney. If we do the 3 chimney, we need to cut down axially. For the 2 chimney, back to the 2 chimney. In our practice now, we percutaneous approach on the brachial artery because of when we cut down, we need to open the arm. It may be the stuck from when we move the C arm. When we do the percutaneous approach, we can close the arm and move the C arm more easier. That is my practice. And the second question is the left renal artery upward. I think we have the many choice to do, depend on the equipment that you have. The first one, I think the problem when we cannulation, we cannot advance the stiff wire because of sometimes it's when we advance the stiff wire, it moves out because of the curve and the direction of the renal upward. The other way that we do, sometimes we try to use the smaller wire, double wire technique. If double wire technique, we can advance to the PTA balloon and swallowing the sheet. The sheet, we have many choice in Thailand. I think in the upward position, I think the flexor sheet may be held to advance easier, more the straight sheet. And the aortic balloon occlusion to help support when we advance. This is another way to do that you done.
I think you did really well with the aortic balloon. That was a fantastic result. A couple of other methods that we do a lot of fenestrated grafts in Australia, and one method we use if we can't get a catheter into a fenestrated vessel is we will put 3 014 wires, 3 into the vessel, then track a CXI catheter, a very slippery, I'm not sure if you have that catheter, over the 013. I think it's more stiff than a standard glide wire, hydrophilic wire. Once the CXI catheter tracks through, it's an 035 catheter, then you can track your stiffer wire. Once the stiff wire is in, usually the sheath will track. So that's one thing we've learned doing fenestrateds.
Thank you. Dr. Watanakitch, in terms of the aortic balloon, is it from the groin or from the arm?
From the groin.
From the groin, okay. Yes. Is it always successful, 100%? How many cases you use like that?
The first case.
I think it's a very good option. That's because in our experience for the chimney procedure, we have 2 cases that have to occlude the renal artery. Both of them is from this anatomy. It's an upward direction. So right now we try to do the periscope or something like that. But the aortic balloon is a very good option. Thank you.
Thank you very much.